Hi guys, very good evening one and all. Hope you are clear with my screen. Hi guys, I'll wait for a few minutes so that we can start the proceedings as quick as possible. So we are left over with the last part. I feel which I can finish within upcoming 1 hour.
Yes, वो आया था मेरे
Yeah, good evening all of you who are on live. So please try to respond me as quick as possible so that we can start the proceedings in the next 2 minutes. I think we are done with the concept of nasogastric tube length determination in the last session. So this is the third part of your Pro Live for batch 2026. The subject is general surgery. Hi, this is Dr. Srikanth from Team MDS Conquer, and I hope most of you are familiar with me. So let's start the session as quick as possible. I think like we are already 60 plus. So wait for 1 more minute. So in this session, I'll be starting with this particular topic like post-surgery. Okay, so these are basically the phases of physiological response to the injury. Phases of physiological response to the injury. So what happens after the injury, which is basically divided into two major phases. One is EBB phase, followed by the flow phase. Okay, followed by the recovery phase. Okay, let's start without wasting any time. Okay, so when you have injury, okay, so when you have injury, so after injury there are some physiological phases that are going to occur in the body. The first one is shock, which occurs in the case of your EBB phase, followed by you have catabolism and anabolism, which is basically flow phase have catabolism, which is again divided into catabolic phase and anabolic phase. And finally, recovery is going to occur. So within few hours after injury, it is EBB phase. Within few days after injury, it is flow phase. And after few weeks, you get recovery from that. Okay, so these phases are very important from the examination point of view, which are covered in 2 to 3 subjects, but specifically my focus is to cover in general surgery. So what happens in the EBB phase? Okay, so EBB phase is the first phase. So it occurs from the time of injury to 24 to 48 hours. Okay, in which there is hypovolemia. That's what it is clearly mentioned here. Okay, where there will be shock, hypovolemic shock. So during this process, what is going to happen? There will be decreasing in the BMR, decreasing in the cardiac output, decreasing in the temperature, hypothermia can be seen. Along with that, there will be lactoacidosis. So these are the things which occurs in EBB phase. Okay, and this explanation part is taken from B&L, the most standard book for the general surgery. Followed by the second phase, that what we have stressed is flow phase, which is called as hypermetabolic phase. So hypermetabolism, so metabolism starts increasing. So there will be increasing in the BMR, increasing in the cardiac output. The temperature increases here. Okay, the temperature increases here. There will be lots of consumption of oxygen takes place here. Gluconeogenesis takes place here, increasing in the leukocytosis, okay, and there will be formation of edema. Whenever you have cardiac output increases, we have already discussed in the last session, whenever there is increasing in the cardiac output, there will be tissue edema that is regularly seen. So already discussed that the flow phase, which is the second phase, has been divided into initial catabolic phase, which runs to 3 to 10 days, then followed by anabolic phase, which is from days to weeks. So what happens in the initial catabolic phase? So initial catabolic phase, there will be increasing in the counter regulatory hormones. Okay. So that is your catecholamines, insulin, or your cortisol, or your glucagon, and all these are going to increase. Apart from increasing in the counter regulatory hormones, we have increasing in the inflammatory cytokinins also, particularly interleukin 1, interleukin 6, and TNF alpha increases. So what happens in this phase? All the fat and the protein which is present in the body, they start getting metabolism. Whenever your fat deposits and the protein deposits, they start dissolving during the process of metabolism. There will be reduction in the weight. And of course, we know that the protein is a combination of amino acids. So whenever amino acids are excreted in the body, there will be increasing in the nitrogen excretion. So these are the changes which occurs immediately after the injury. Okay. So, right. So what is the first phase that occurs immediately after the injury is EBB phase, where there will be shock. Signs of shock will be seen in the case of EBB phase. Okay. What happens is hypovolemic shock is going to occur. Temperature is going to decrease, hypothermia. Apart from there is critical increasing in the catecholamines, cortisol and aldosterone can also be seen. Followed by this, you have a hypermobilic phase, which is a flow phase, which is basically divided into initial catabolism and final anabolism. Okay, I hope you guys are clear with these phases, which are very, very important from the examination point of view. So now we'll try to solve few questions which are given in the worksheet related to this. Which of the following is a characteristic feature of EBB phase of metabolic stress response to the surgery or trauma? The injury can be during the surgery. It is basically injury. The injury can be during the surgery or it can be during the trauma. So what happens here? Okay, if you're talking about BMR we have already discussed. During this phase, the BMR decreases. Okay, tissue edema is seen in the case of flow phase, not here. Leukocytosis is seen in the flow phase. Increasing in the BMR is seen in the flow phase, whereas decreasing in the BMR is seen in the case of EBB phase, where EBB is going to have less temperature, decreasing in the temperature, hypothermia. The answer is C. And I hope you guys are very, very clear with this. Next comes 68. Which of the following hormone, keyword not predominantly involved in regulating the EBB phase of metabolic stress response? Yes, catecholamines are involved, cortisol is involved, aldosterone is involved, insulin is not a part of it. Okay, right. The answer is D. Next comes, which of the following is a characteristic feature of catabolic phase of flow phase? We are talking about the second one, flow stage. Okay, in metabolic stress response. Okay, so what is going to happen? It's clearly given it is catabolic, so it's nowhere related with anabolic. So what happens? There will be increasing in the nitrogen excretion, right? It's not decreasing, it is increasing in the nitrogen excretion. This increasing in the nitrogen excretion is basically due to the mobilizing of your fats and protein stores. Fats and protein stores, they got mobilized. That leads to increasing in the excretion of nitrogen. That leads to decreasing in the weight of the patient. So there will be weight loss to the patient. Clear, guys? Done? Need a response on the chat box so that we can proceed to the next topic. So we are done with the first topic of today, which are basically phases that occurs after injury, phases that occurs after surgery, phases that occurs after trauma. First phase is EBB phase. The second phase is flow phase. Finally, after EBB and flow, what is going to happen? Recovery is going to happen. The next important thing I want to stress a little on gas gangrene. Of course, it is already covered in the smart videos. Okay, a little on gas gangrene. And first and foremost thing I want you guys to make a note is the organism responsible for occurrence of gas gangrene, Clostridium perfringens, that most of you are familiar. So whenever you have a gas gangrene picture, okay, it looks like this, either hand or either leg, they're going to give you with all this necrosis and uh, all this appearance, okay, which you can imagine this. You can keep a note on this diagram. The diagram looks like a drumstick appearance, but this is not the basic drumstick. The drumstick we'll be talking in the microbiology, okay. So this particular organism on microscopic photograph, it appears like a drumstick. It appears like a drumstick appearance. So do make a note. It's a microbiology related stuff, okay. Please do make a note of it. So what is going to be the treatment for this? The treatment always for the gas gangrene is remove the necrotic part as quick as possible, okay. That may be fatal in the future, okay, right? So you have to do the required treatment as quick as possible. That is, surgical excision of that part has to be done, and immediately you have to give antibiotics to the patient. That is, penicillin and clindamycin has to be given. And B&L is clearly telling that even HB work is going to work out well. That is hyperbaric oxygen therapy, which is again a treatment protocol that is most commonly used in the case of osteoradionecrosis. So most of us are familiar regarding osteoradionecrosis, which is a part of us, okay, oral path and oral surgery, oral medicine. So what is the treatment for osteoradionecrosis? The treatment for osteoradionecrosis is hyperbaric oxygen therapy. So this hyperbaric oxygen therapy can be used in osteoradionecrosis, can be used in frostbite, can be used in many other conditions. Even it can be used in the case of necrotizing fasciitis and all these conditions where you can use this hyperbaric oxygen therapy. But in B&L, it is clearly mentioned that hyperbaric oxygen therapy can be used in the case of your gas gangrene condition also. But the etiology, the reason why it is showing better results is not clear till the date, okay. We don't have a very clear-cut idea. It's clearly mentioned in so BL and L, please do make a note of this, okay. But hyperbaric oxygen therapy can be used to get a better results in very, very severe cases of gas gangrene. The basic treatment for the gas gangrene is surgical excision followed by giving antibiotics, okay, right. So if we check out the questions which we have given here, is question number 70. A 35-year-old construction worker presented to the emergency department with a pain, swollen right leg after a heavy object falling on his leg at the work site. Which of the following is the causative organism for this particular condition? This is a gas gangrene case, and the causative organism is option A. Very nice. Done. The next one, which of the following is the characteristic feature of gas gangrene that helps in differentiating it from other soft tissue injuries? Okay, it causes the necrosis of the tissue, presence of foul smell, right? And it produces gases along the planes of muscle, and it produces hemorrhagic bubbles, okay. The answer is E for this particular question. The next one, which of the following is a characteristic finding in the biochemical profile of the patient who is suffering from gas gangrene? You will be having metabolic acidosis, respiratory failure, and hemolysis. The answer is D. Okay, top to bottom about gas gangrene is covered in your smart videos, okay, and I hope you're done with under the topic of infections, okay. Next, so we'll jump into the next part, that is types of edges. Types of edges were already discussed, okay. The types of edges are sloping, undermined edges are seen in the case of TB, sloping edges are seen in the case of healing ulcer, punched out edges are seen in the case of syphilis. Few other conditions we'll be talking now. Then you have rolled out edges are seen in the case of basal cell carcinoma. Averted edges are seen in the case of squamous cell carcinoma. I hope you guys are very, very clear regarding this. Clear? Done? So these are the basic examples and the basic edge types which are seen in the case of ulcers. Clear? I need some quick response in the chat box so that we can proceed to the next part of our discussion. Okay, nice, very good. So next question is, which of the following statement about ulcer is true? No except here. Which of the following statement about ulcer is true? So we have already discussed about the different parts of ulcer. Base is what we feel. Floor is what we see. We have already discussed this yesterday. Base is what we feel or what we can palpate. Our floor is what we see. So the option A is base of an ulcer is better felt than seen. Yes, absolutely right. Undermined edge is most commonly seen in the TB ulcer. Of course, we have discussed this. And in the ulcer, sometimes in the healing ulcer, we can see white zone. Okay, we can see white zone in the healing ulcer is due to fibrosis of the scar. Yes, it is right. Okay, the answer is D. Okay, the answer is D. Then I want to add a note. Okay. So, I mean, like once you are going deep into oral path and oral medicine or like radiology, so you'll be having punched out. We were discussing like punched out lesions with regular borders are seen in X-ray. Punched out lesions with regular borders are seen in X-ray of multiple myeloma. Same. M and M are regular. Very easy to remember. Regular borders, punched out regular borders are seen in M and M. Okay, because M and M are regular, whereas E and G are irregular. Okay, so multiple punched out lesions which are irregular is seen in EG, eosinophilic granuloma. Irregular punched out are seen in EG. Regular punched out are seen in MM. So now, apart from the regular example, which is there in the textbook, or let it be B&L or a little bit of controversy, there is an SS Das. Apart from the regular examples, I'll try to add few more other examples which are taken exclusively from B&L when they're talking about that particular ulcer. So please do make a note of it. Most of us are familiar. Undermined edge, we have already discussed. Most of us are familiar. Undermined edge is seen in the case of TB. TB ulcer, undermined edge is seen. TB ulcers, when I'm talking in the oral cavity, because we already have a question in 2017 Neet examination about TB ulcer. TB ulcers in the oral cavity are painful ulcers. They are painful, they are multiple. Now the other example that I want to stress of undermined edge is soft chancre. The undermined edge is soft chancre. The very commonly asked example for this is TB, definitely. The other example, if you want to add, you can add it. Soft chancre can be coming under undermined edge. Next one, punched out. I told you there are so many things moving around punched out, but the most common punched out is syphilis, gamma, seen in the case of your tertiary syphilis. This is the most common example that is given in the basic description of different types of edges of ulcers. The other you can add a note is deep trophic ulcer. You can add an example of soft is done. You can add an example of hard canker. Punched out crater-like depression is seen in the case of interdental papilla, is seen in the case of ANAG, your perio. And the other is aphthous ulcers, which are part of your oral medicine. Coming to the radiology, wherever you find out punched out, those are the next examples. So punched out regular borders. Regular is MM and irregular is EG. Regular is MM and your irregular is EG. Regular is your MM and your irregular is EG. And I hope you remember the punched out wala diagram. Okay, the punched out diagram will be like this. The punched out diagram is like this. Punched out means 90 degrees it will be. So punched out is seen in gamma, most common example, deep trophic ulcer, hard chancre. Punched out crater-like depression is seen in the case of anag in perio. Punched out ulcers can be seen in the case of aphthous ulcers in your oral medicine. In radiology, punched out regular are MM, irregular are EG. Clear, guys? Clear? Done. Okay, chalo. Next one is sloping ulcer. Sloping ulcer we have already discussed. Basic ulcer, trauma. Traumatic ulcer comes under sloping ulcer. Apart from this, one more example I want you to add is venous ulcer. Venous ulcer is also sloping ulcer. Rolled out, yesterday we have discussed the best option is going to be BCC. The best option is going to be BCC. Sometimes it may be overlapped with the description of SCC also. But preferably whenever you see a unique line rolled out, your answer should be BCC always. Clear? Clear, boys? Clear, clear? Okay, nice. So next coming to the few other things which we have already discussed in yesterday's session. Which of the following is true? Red granulation tissue in the floor is telling you that the ulcer is healthy and healing. Red means good blood supply is there. Red granulation tissue is telling that the ulcer is healthy and healing. Yes, absolutely right. Pale smooth granulation tissue. Pale smooth granulation tissue is indicating it is a slow healing ulcer. Pale smooth granulation tissue, yes, right, slow healing ulcer. Washed leathery floor. Washed leathery floor is seen in the case of tertiary syphilis, gamma ulcer. Yes, it is right. The answer is D, all of the above. The answer is D, all of the above. Okay. Of course, we have discussed black mass at the floor is a suggestion of malignant melanoma. Of course, it is multicolor. Of course, it is multicolor. When compared to other options, you can blindly go for malignant melanoma as an answer. For black mass at the floor is a suggestion of malignant melanoma. Okay. Marginal ulcer is basically an ulcer. It's basically an ulcer which is formed from the scar or burn. That is basically a low-grade squamous cell carcinoma. Already discussed in the smart videos. You have a special 5 minutes video on this ulcer. So ulcers videos are very, very important. Every individual ulcer, Basal ulcer, every individual ulcer, I have prepared a video, okay, which will be there in your general surgery folder. So please go back and do it. Ulcers are very, very important in general surgery from examination point of view. Okay, jumping into the next one is question number 85. Ulcers seen in the secondary syphilis are, yes, patches can be seen. Snail tract ulcer can be seen. Condyloma lata can be seen. D, all of the above. Okay. Phases of syphilis, stages of syphilis, primary syphilis, secondary syphilis, tertiary syphilis, all these are important. Okay. Ulcers seen in the secondary syphilis are right, all of the above. Gummatous ulcer is seen in the case of which type of syphilis? It is seen in the case of tertiary syphilis. Okay, right? So a few questions we try to solve from ulcers. Okay, right? So I hope you guys are very, very clear regarding this. I'll try to move ahead of this. So carotid body tumor, yesterday we have discussed the carotid body tumor. The carotid body tumor in the case description part, we have clearly mentioned the carotid body tumors are most common in 4th and 5th decade. It is also called as potato tumor. Carotid body tumor are most common in the 4th and 5th decade of the patient. And it is most commonly seen in the patients who lives at higher altitudes. So whenever these patients living at higher altitude, your oxygen tension will be less, hypoxia will be more. So whenever there is a hypoxia, this carotid body tumor area at the bifurcation will get activated. That leads to hyperplasia. That hyperplastic tumor is called as carotid body tumor. Okay. That is called as carotid body tumor. We have already discussed about the location. The main problem associated with carotid body tumor surgery is the tumor blends with the bifurcation of carotid artery, which is very, very important artery for us. Okay, so that is the reason why you cannot simply go for a blind surgery for this. Of course, we need to go for excision, but it has to be carefully manipulated. Thereby, which we are talking about, Fontaine sign or Lyre's sign. Yesterday we have discussed it. Okay. Which of the following is true related to the carotid body tumor? Yes, it is unilateral. Surgical excision is the treatment of choice. Okay, non-chromoferin paraganglion, right? So answer is D, all of them. All these points yesterday we have discussed in the class. Right? So we are done with carotid body tumor oriented questions. Then jumping into one more important head and neck. Okay, when I'm talking about tumors, okay, tumors of head and neck in oral general surgery. Okay, so tumors are very, very important. Okay, apart from ulcers, burns, the third important topic for me for the Neet or Inicet is swellings and tumors, cysts of head and neck. And of course, once we are done with carotid body tumor, the next preference of choice by most of the paper setter is cystic hygroma. Okay, cystic hygroma, the basic description part they are going to give you as it is a tumor which is seen in the case of infants and young individuals. Immediately after the birth, the baby is having a big swelling around the neck or around the face. Your answer is cystic hygroma. Okay, your answer is cystic hygroma. Okay, we'll try to solve few lines related to cystic hygroma. The first one is cystic hygroma is associated with syndrome. Cystic hygroma is associated with syndrome. Okay, it is associated with Turner syndrome. It is associated with Turner syndrome, and most of us are familiar regarding the Turner syndrome. So what is the chromosome karyotyping that we give for Turner syndrome? It is 45XO. Okay, it is basically 45XO. So what is this 45XO? Okay, in a normal individual, regularly we are going to have 44 autosomes plus 2 sex chromosomes. But the Turner's patient is going to have 44 autosomes. Instead of 2 sex chromosomes, they are going to have only 1 sex chromosome. That is only X. So that is the reason why they are called as 45XO. The number of autosomes are same like us. But once you're talking about sex chromosomes, where we have 2 sex chromosomes, either XX or either XY for us, okay, but this fellow is going to have only X0. Only X chromosome is present. So that is called as the karyotyping of your Turner syndrome 45XO. In detail, we'll learn about the Turner syndrome either in general path or in oral path oral medicine. So keeping that aside, the other important thing I want to stress on is other typical word that most of us are familiar is Turner's hypoplasia. Again, oral pathology, oral medicine line. What is this Turner's hypoplasia? Turner's hypoplasia is basically local enamel hypoplasia. It is local, it's not generalized. It's local, means it is seen in only a particular part. It is seen only in a particular part, not in all the parts. Okay. So what happens regularly? You consider these as your primary teeth. The primary teeth are going to have underlining permanent buds. So what is going to happen? Primary teeth starts their infection at the furcation area, whereas the permanent teeth, the infection starts at the periapical area. So this is a very important point when you're talking about your dental subjects. So primary teeth, the initial lesions in the case of your posterior teeth can be seen in the furcation area, whereas in the case of permanent teeth, they are seen in the periapical area. So what is there in the furcation of a primary molar? You are going to have your permanent tooth bud. So whenever the infection spreads, the infection is going to hurt the upcoming permanent tooth bud. So thereby the formation is having a problem. The formation is having a problem. That is particularly enamel formation. So that leads to hypoplasia of enamel only in a particular tooth bud which was previously affected by the primary teeth associated with that. So that is the reason why it is called as localized enamel hypoplasia, which is called as Turner's hypoplasia. I hope you are clear with Turner's syndrome and Turner's hypoplasia. Now I want to jump into the next part. Cystic hygroma is most commonly located at. You can see it is most commonly located in this condition. In this diagram, it is condition. It is most commonly located at posterior neck. What is the treatment? Excision. Nicely remove it. Okay. Surgical treatment of cystic hygroma is surgical excision. Sometimes excision cannot be possible immediately because of the size and considering everything. In such conditions, you can give sclerosing agents. The sclerosing agents are going to decrease the size of the lesion. So once the size of the lesion is decreased, then you can go with the surgical excision of the cystic hygroma. Okay, next we'll check out which of the following is a false statement. The keyword in the question is false statement regarding the cystic hygroma. Brilliantly translucent lesion, right? Surgical excision is the treatment of choice, right? It is a type of lymphangioma, right? A cyst filled with blood. No, it is not filled with blood. It is basically filled with lymph. It is lymphangioma. It is filled with lymph. The answer is D. So once we are done with cystic hygroma, then I want to jump into brachial cyst. Brachial cyst. It is also called as brachial cleft cyst. It is also called as brachial cleft cyst, which is congenital. It is present most commonly in the lateral aspect of the neck. You can see it is present in the lateral aspect of the neck. Painless fluctuant mass in the anterior triangle, often behind the sternocleidomastoid muscle, near to the sternocleidomastoid muscle. So this location is very, very important. And if you check out the key important times, already top to bottom about this, everything was discussed in your smart video session. And I hope you can go back and check it. All the students who are registered with MDS Conquer, you can go back and check. Nothing wrong. The most common site for the brachial cyst is upper 1/3 of sternocleidomastoid. Brachial cysts are obtained from clefts. We have discussed brachial cleft. What is brachial cleft? It is most commonly originated from the second cleft. Second is important. And the most common site of internal opening of this fistula. So brachial cyst, further if it is not handled well, it converts into fistula also. Okay, we read cyst plus fistula. So fistula can have two openings. One is internal opening, second one is external opening. So please write down what is internal and what is external openings. I'm talking about fistula. They can ask you one important previous question for fistula for the medical friends is fistula, brachial fistula is lined by ciliated columnar epithelium. Brachial fistula is lined by ciliated columnar epithelium. I told you there are two openings. One is external opening. Second one is internal opening. Coming to the external opening. So external opening is situated in the lower 1/3. Is situated in the lower 1/3 of the anterior border of sternocleidomastoid. Is situated in the lower 1/3 of the anterior border of the sternocleidomastoid muscle. Next one, internal opening. Internal opening is seen in the anterior aspect of the the posterior fasciculae pillar just behind the tonsil. So please do make a note of this external opening and internal opening of the fistula. Very frequently asked is fistula, brachial fistula is lined by ciliated columnar epithelium. So treatment of most of the cysts, head and neck cysts is excision. Again, treatment of brachial cyst is excision. Done. Okay, next one is 98 question number. Dermoid cyst is a form of, it's a form of cystic teratoma. It's a form of cystic teratoma. Which of the following statement is true about basal cell carcinoma? Also called as marginal ulcer. No, marginal ulcer is a different category. It is a low-grade squamous cell carcinoma. It's a low-grade squamous cell carcinoma, which is seen in the case of your burns patient or patients with scar. So it is nowhere related to this. And the second one is, it metastases to the regional lymph nodes. No, we have already discussed basal cell carcinoma. The mode of metastasis of basal cell carcinoma is by direct invasion, direct spread, not by lymph or not by blood. Normal lymph carcinomas, they spread by either lymph or blood. This is by direct invasion. Similarly, like your, which type of carcinoma of your thyroid spreads by direct invasion? Anaplastic carcinoma of thyroid spreads by direct invasion. Okay, initially, followed by it spreads by either lymph or blood. This is basal cell carcinoma only by direct invasion. That is the reason why basal cell carcinoma is called as benign carcinoma, because benign tumors only spreads by direct invasion. It is a benign featured carcinoma. Okay, and most of us are familiar. Basal cell carcinoma is also called as tear carcinoma because it falls in the areas where the tears are going to be there. It is also called as rodent ulcer because this looks like a rat eaten. Okay, it is also called as benign carcinoma because it spreads by direct invasion. This is your Neet 2024 question. What is the mode of spread? Which of the following carcinoma, the mode of spread is by direct invasion? The answer is basal cell carcinoma. Okay, so option A and B are eliminated. So D is also eliminated. The answer is C. It is radiosensitive. It is radiosensitive. Okay, done. Then coming to the next one, CS of fluid blood glucose levels are very, very important. Reason one, it is used in the application part. So where application part one is to identify the types of meningitis. So meningitis is caused by different etiology. It can be fungal meningitis, viral meningitis, or bacterial meningitis, very specifically TB meningitis. There are so many types of meningitis. So how you differentiate different types of meningitis is basing upon the biochemical features, biochemical investigations obtaining from cerebrospinal fluid. So you take cerebrospinal fluid from the individual, send it for the biochemical investigations. Basing upon the findings, you can differentiate whether it is which type of meningitis, and you can start the treatment plan accordingly. One. Second condition where this is useful in identifying is when you're talking about your maxillofacial fractures. In maxillofacial fractures also, cerebrospinal fluid glucose levels will definitely help in identifying the type of fracture. Okay, right? CSF, rhinuria, and all these things we'll be discussing in the oral surgery. That's a different entry, but do make a note. It can be used in identifying the types of meningitis, and it can be useful in your maxillofacial surgery. Right, two areas. But as of now, I want you to focus on, I think because the 2026 batch students does not have access to the general medicine physiology folder because we are upgrading the folder. So in which you are going to have types of meningitis, which is very, very important. People of 2025, yeah, they have access. Okay, please go back and check the types of meningitis video. Okay, so please do 26 wala people, please do mark it, keep it. Okay, so types of meningitis has to be done. Okay, from your general medicine physiology folder, where we are going to talk about different types of biochemical values. Now they are asking in this question about the normal glucose level. So this is the closest option. So normal glucose level is 45 to 55 milligrams per dm. Similarly, if you want to make a note, This is a normal protein in CSF, that is 15 to 45 milligrams per deciliter, and the normal pressure is 50 to 80 mm of hydrogen, sorry, mm of water. 50 to 80 mm of water. Okay, so please do make a note of these values. Okay, 100th question, the answer is C for now. Types of meningitis, yeah, we will be doing in the general medicine session. Next one, 101. Most of you are familiar. We have already discussed the sequence of event that occurs in the TB, which starts initially as lymphangitis, that is your cervical lymph nodes, followed by you will be having matted lymph nodes, followed by you will be having the cold abscess, followed by the cold abscess is going to break down, that is called as collar-stud abscess. Okay, and followed by it's going to open up with a sinus opening. It's going to open up with a sinus opening. This breaking down is called as collar-stud abscess. This is a collar-stud stage. This is a collar-stud abscess stage. Okay, clear? So this is basically a part of your TB, stages of TB. Okay, nice. So jumping into question number 1 or 2, I hope you can handle this question number 1 or 2. A 45-year-old diabetic patient present with rapid progressive swelling, severe pain, redness in the lower limb. On examination, the skin appears dusky with the areas of bullae and cryptus. Cryptus are nothing but crackings. These are basically crackings. Right, so these are basically crackings. Basically, you can see basically they are crackings, and the patient is hypotensive, and the most appropriate next step in management of this condition is, what is this condition called as? So what is this condition called as? Yes, this condition is gas gangrene, and the treatment of gas gangrene is immediate surgical debridement, and you start broad spectrum antibiotics IV. Answer is C. Broad spectrum antibiotics IV. Right, very good. Next one, 103. A 55-year-old male patient with poor with a poor controlled diabetes presented with severe pain in the lower limb, which has rapidly progressed over past 12 hours. On examination, the limb is swollen, tender, with the areas of skin discoloration and bullae formation. The patient is hypertensive. After administrating into the hospital, the pain decreases without any treatment. And the clinical clue with the diagram is, yes, right, necrotizing fasciitis. Very good. And question number, the last two questions are basically moving around cricothyroidectomy. So cricothyroidectomy is a very emergency procedure that we regularly prefer over tracheostomy. The reason for cricothyroidectomy is it is easy. It is easy and which requires a minimum instruments. Okay, minimalistic instruments are required. It can be done quick, it can be done fast, it is a little bit of easy. So that is the reason why in an emergency situation, cricothyroidectomy is preferred when compared to the tracheostomy. But the only disadvantage of cricothyroidectomy is cricothyroidectomy can lead to subglottis stenosis, and it can lead to change of your voice over a period of time. Vocal changes can occur, and it can lead to subglottic stenosis. Okay, clear? right? So 104, which of the following is one of the primary advantages of performing cricothyroidectomy in an emergency situation when compared to any sort of opening of your airway in emergency cases? Is answer is C. It is quick and requires minimal equipment. Next one, 105. Which of the following complication is associated with cricothyroidectomy, particularly with long-term usage of tubes and everything? Yes, it is subglottic stenosis. If you want, you can add a note, subglottic stenosis, plus it can lead to voice change, vocal change, vocabulary change. Okay. So those are the things which I want to make a note. So I'm done with this particular session for today. Yeah, and please do let me know anything from your side regarding these live sessions, any modifications to be done from the team side regarding the live sessions, which can be implemented in the upcoming live classes that we are planning to perform. Okay, right? So as the dates of Neet 2025 were not out, okay, so we may have few interactive live sessions with 2026 batch, so 2025, and of course we will plan some sessions for 2026 also. This class of three parts, part 1, part 2, part 3, that we have done from past 2 days is basically to show how the interactive classes of ProLive will be there for students who are requesting for demo before joining. Okay, so keeping that in mind, team has decided let's take few sessions. Okay, so let them know like how we interact and how we discuss the questions and everything. Okay, as this is a live session, and most of you are not done with the schedules, because normally already 2026 batch people are already done with all these schedules. Like when I'm going live for those students exclusively, we'll try to go a little bit fast. Reason is they know most of these topics, and I particularly know which is not cleared from the student side, which they are not clear from their side, because I every day on a daily basis I check the schedule, I read the schedule with them on a daily basis. I am into the schedule, so I know what is there in the smart videos, I know what is there in the smart notes, I know what is there in the questions, whatever they are given or exposed. So keeping all these things in mind, I'll try to take pro live sessions, like where contents which they already know, I'll try to go a little bit fast. Contents which they don't know, I'll try to go a little bit slow. Okay, right? So rest everything will get upgraded, and within 15-20 minutes we'll be having a live session for 2026-2025 batch about the discussion of the schedules and everything, because until now we are just waiting for the dates to be out and we don't have any update from NBE. So I have a plan which we'll be discussing. So I'll be coming again live probably within 15-20 minutes, so that we'll have a discussion of the schedule. So 2025 batch, please get prepared and get ready. Okay, see you. So I want your suggestions, right? I want your suggestions and everything. Okay, so hope you like the video, like the interactive session, whatever we are doing. Okay, after a long break, I'm coming live again on YouTube. Okay, so to address you, so we'll try to interact more and more in the upcoming few days. Okay, take care. Hope this session is useful for you. Bye bye, see you, take care.